Heyo, and welcome back. Today we will keep going and continue our conversation about the heart. Instead, we'll do the fun stuff besides, QRS complex and start working on the cardiac arrhythmias. So, let's go back. Normal heart rate is about 60 to 100 beats per minute. Sinus rhythm is going to be regular P waves and QRS complexes showing up, and fibrillation is when the depolarization is not in sync, and tachycardia is going to be, of course, caused by toxic conditions, bad conditions, and bradycardia can either be due to stenosis, decreased venous return, or in a healthy athlete. Why in a healthy athlete? It's because their hearts are so much more effective than we are, right? So I'm okay, healthy young lady whose heart rate is about um, it's about like 80. 80 is pretty standard for a normal person. But let's say let's compare my heart rate to like Michael Phelps. Michael Phelps' heart rate is probably like 40 beats per minute, something crazy low like that. And you always have to keep in mind the patient's lifestyle because, you might freak out and go like, oh shoot, this person has bradycardia. But think about Michael Phelps. First, think about his height, right? So the heart has to contract quite a lot harder, and the ventricular filling is going to take longer, and there just has to be a longer contractility period because he's so much taller than I am. He has to pump all that blood from his feet to all the way to his head. I'm not really quite sure how tall he is, but let's just assume that he's taller than 6 feet. So of course it's going to take a lot longer. Besides that, that's already 1 point for him for having a slow heart. But two, he's a phenomenal athlete. Like nobody swims that fast without having a good heart condition. Like his heart is in great top-notch shape. So with being in such great shape, his heart is just more efficient at contracting. Like there's no wasting of energy. There's a lot better recruitment, and there's most likely less fat on his heart than the average person. Yeah, fat on the heart is normal because it cushions the heart, but athletes just have a lower amount of body fat. So you always have to keep the patient's lifestyle and their just basic physiology in mind whenever assessing their heart. Okay, so atrial fibrillation really occurs in the elderly. Occasionally, it can occur in younger people, but generally that's some kind of congenital condition. And this occurs when the atria don't beat in sync. There's going to be an irregular heartbeat. So you can't really find a pattern at all. There's not going to be any P waves and an irregularly spaced QRS. And it's caused by hypertension and coronary heart disease. This is bad, because this is the first sign that this person is at high risk for a stroke due to the oxygen deficiency and the disrupted blood supply. So the ventricles don't have enough blood to supply to the aorta, and because the atria are fibrillating, so it's fluttering, and as a result, the atria can hypertrophy, and then look at the EKG, all these bumps. There's no definitive P waves, and all of these are irregularly spaced, so it's going to be irregular. Let's look at here. See, there's not really a good pattern to any of these, and there's no P wave. That's more of a T wave. Maybe this is a P wave, but here's a P wave back, but oh wait, it's gone. And then the widening of the T wave, and also the shortening of the QT interval. So this person also suffers from hypocalcemia. Let's go look down here. Yeah, see, this is very irregular. Here, there's one P wave, but there's no P wave here. There's no P wave here. Oh, here's a T wave, but it's irregular again. So, I have to advise you to just really look at a lot of real life examples of AFib or VTAC or something like that, because though nice and useful to see it all zoomed in like that, you don't see that in real life. This is what you're going to see in real life. Okay, let's define atrial flutter. This is going to be supraventricular tachyarrhythmia, so above the ventricles, of course, deals with atria, and that's going to be caused by a micro reentrant rhythm within the atria. So this is going to be a lot more regular than AFib, though the atria are not working perfectly. It's not. It's caused by a different mechanism than AFib. So it's asymptomatic, but with age and let's say bad lifestyle, it can degenerate into atrial fibrillation. And on the EKG, it shows up as a sawtooth appearance. And it's really definitive. You see it and you're like, oh shoot, this is atrial flutter. Look, sawtooth, 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 sawtooth. Compare it to AFib. AFib's gonna be all this little lines, no P waves, line. Oh, look, everything's irregular. But atrial flutter is gonna be regular, like sawtooth. And this is like two boxes, two boxes, two boxes. So what happens with atrial flutter? So this is more of an anatomy issue versus a disease pathology issue. So there's two types, type 1, type 2. There's going to be a re-entry of electrical activity. So electrical activity from the SA node should go straight to the AV node. But sometimes it just loops around and goes right back into the AV node, or I'm sorry, not the AV node, the SA node. SA node doesn't know what to do with all this extra, electrical activity, and it just keeps fluttering. There's still stimulation, so it's gonna contract again. But maybe they haven't finished contracting completely, so it's going to be like a weak kind of twitch. And we don't want the heart to twitch. We need it to contract fully in order to eject the blood. Type 2 is going to be rare. There's going to be various re-entries, so it's not just one counterclockwise loop around. It's going to be like counterclockwise, and it's going to affect the ventricle, something like that. But basically, the extra electrical activity going back into the SA node and AV node can affect the rate, the heart rate, and the electrical conduction, because it just interrupts with a new cycle. Because one side of the heart actually is producing the electrical activity a little bit faster than the other side, and with the electrical re-entry, it can block the slow current and only depolarize the fast side. So that's why there is going to be still some contraction. It's not effective contraction, but there is still contraction. Okay, ventricular fibrillation is completely erratic. This is way more dangerous. Atrial fibrillation is concerning, but it's not going to drop your patient dead. Ventricular fibrillation will. So this is when the patient needs to be defibrillated. No blood is being pumped at all, because the fibrillation occurs also because of the recurrent entry. This is a different path, though. It's going to be macro re-entrance from the ventricles, not just the atria. But it's problematic because the AV node's not even going to transmit the signal, because unlike the unlike the atria where there's a fast and a slow road, so at least the fast road can conduct something. The AV node transmit the sound signal to the bundle of His, and remember when I said that the Purkinje fibers and the bundle of His has faster action potential depolarization, so they occur at the same time, and if that doesn't occur, there's no signal to go, and both are going to be blocked, there's not going to be any pumping at all. The heart's just going to twitch, and look at this crazy rhythm. You can't tell if there's you can't tell any P waves from T waves. QRS complex is gone. This is super concerning. Patient needs to be defibrillated immediately, along with epinephrine to be given. Okay, heart blocks. So sinoatrial block is going to be no P waves. So that's convenient. That's pretty standard to know. Look at this. Some QRS complex, but there's no P waves. Strange. And then in the AV node blocks, there's different types. There's first degree down to third degree, and it can be blocked by several different things. And this is really important to show old heart attacks, because something called a Q wave will occur, and that's when you know that this person had a heart attack some time ago. So first degree is benign. There is only the PR interval prolonged, so not terribly concerning. It's just a little strange. And then so that's like, and then sorry, in the second degree, or it's also known as Mobitz type 1. That is when the P, or let's see, the PR interval is going to be prolonged, and it gets longer, and it gets longer, and it gets longer, and then all of a sudden a beat is dropped. And then the third degree is going to be like the ones with the bunny ears, but let's go through it. So the second degree is Mobitz type 1, like I said. It's prolonged PR interval, and then QRS is dropped. So it just kind of like keeps going, and then all of a sudden, no more QRS, and then restarts. So this is going to be irregularly regular. Irregular because this is obviously not a normal heart pattern, and regular because the drop beat is like every third or fourth beat. So in type 2, there isn't any dropped beat. Oh, there is a dropped beat, but there's no lengthening of the PR interval. So it's just, your heart is beating, and then all of a sudden the QRS complex is dropped. So this one needs a pacemaker because that can progress to the third degree heart block. Third degree is going to be a complete heart block. There's not any coordination at all. It's something called an AV dissociation, and it is different from the ventricular fibrillation because the heart is still somehow pumping. It's not like completely out of sync. So with the ventricular fibrillation, ventricles and atria are nothing is coordinated. But with the complete heart block, the ventricles are still communicating, the atria are still communicating, but there's not any coordination between the two. So the P waves will just go straight through the QRST complexes, and then the P to P intervals are actually going to be regular, and there's going to be a regular R to R interval, but these two are not going to be related to each other, so you're just like, oh, okay, what's going on here? As you can see here, like P, the waves are going to be regular. They do show up, but there's not going to be any association. So the problems with the conduction system can be caused by Lyme disease, but in general it's more caused by heart or conduction issues due to a cardiogenic shock or cardiac arrest. Ectopic beats are going to be your extra beats, and those are going to be caused by ischemia, plaques, or toxic irritation of the AV node, problems with the Purkinje system or the myocardium. And then all you get is an extra little P wave in the EKG, and then it's followed by a narrow QRS complex, and then a scoop as your S wave in the ectopic ventricular contraction. So ectopic atrial is extra P, ectopic ventricular is going to be a scoop. Ectopic beats are somewhat concerning because that can lead to some kind of heart block, or it might be a precursor to one of the heart blocks. And of course, the ectopic beats can be a precursor to AFib, and AFib can lead to stroke. So everything kind of leads back to strokes. Okay, Wolff-parkinson White is going to be the most common type of congenital ventricular pre-excitation syndrome. So let's break this down. Congenital, kids born with it, some kind of genetic problem or kind of a problem in heart development. Ventricular pre-excitation, so the ventricle is going to fire a little bit too early, so atria is still kind of contracting. Ventricular ventricles will the ventricles will contract, interrupting the atria contraction, so there isn't going to be enough blood filling the ventricles to eject anything significant. So what's the heart going to do to compensate for this? There's not enough blood coming in for a good ejection, so the heart rate's going to go up. So let's bring back me versus an Olympian, Michael Phelps. So my heart rate's going to be way faster because my heart just doesn't eject as fast. This doesn't mean necessarily that I have ventricular pre-excitation syndrome, but that's just for an example. Like my heart is compensating because it's just not as effective. So in these patients, it's going to do the same. The heart's not ejecting any significant blood in order to perfuse the body. So of course their heart rate is going to be faster. So this is caused by an abnormally fast conduction pathway through an accessory nerve bundle called the bundle of Kent, and this bypasses the AV node and shortens the repolarization of the atria. So there's not going to be a pause. So the ventricles are going to contract too early, interrupting the repolarization of it's going to interrupt the atria and shorten the repolarization time. And then, of course, it's going to go crazy fast. So a delta wave is going to show up along with a widened QRS complex and a shortened PR. So what's a delta wave? A delta wave is this. So this strange kind of curve up, and here's the shortened PR complex. There's not there at all. Let's look at this patient. So there's going to be something called ST elevation. Oh man, look how elevated it is. You always try to find a decent axis in the middle of all of this. So not only does this patient really have the elevation, also have a couple of depressions. Let's look. Here you go. Here's a delta wave. It's a bit subtle, but like I said, you just need to practice reading EKGs a lot in order to really crank them out quickly. Okay, so heart attacks, myocardial infarction. This is when the blood supply is interrupted and necrosis occurs. So the most common blockage to occur is in the left anterior descending artery and the right coronary artery. So remember, anterior descending artery is going to be affecting the apex. So this is the longest one, the longest artery in the heart. So sometimes there's going to be a left circumflex blockage, but that's kind of rare. And the necrosis of the myocardiocytes will cause pain. And then there's going to be the ST elevation myocardial infarction, also or transmural infarction, also known as STEMI. That is when the full thickness of the myocardial wall is involved. So it's not just like an endocardial block or an epicardial block. It's going to be all of the layers of the heart. And that's going to result in something called a Q wave. So here's your Q wave. Here's your Q wave. So let's look at this a little bit more, right? Here's the Q waves over here. So QRS. And this is here's the ST elevation. Look, it's so much higher from your standard block. And then there's going to be these Q waves. Q wave. ST elevation. More Q waves. And the Q waves are permanent. So once you've had the heart attack, it's going to be there forever. And the size of the Q waves kind of indicate how bad that heart attack was. Okay, so a non-ST segment elevation and myocardial infarction is going to be NSTEMI. And this is when only the subendocardial infarction is occurring. There's no complete occlusion. So this one's actually not as bad as the STEMI. STEMI is bad. STEMI is the entire layers of the heart. NSTEMI, not bad. That's how I remember it. So only a third of the myocardium is damaged or affected, and it's going to cause something called an ST depression. So it's going to cause that little scoop. STEMI is going to be the ST elevation. Here you go. This is normal. And then end STEMI is also going to have that T inversion occasionally. So let's read the EKG again. Okay, here's this here's the elevation of the P wave. So QRS. Here's the scoop. So this is going to be the end STEMI ST depression. Let's see if we can see. Let's see if we can see if there's any depression. QRS. The Q is pretty big here. Here's your T. Okay, so this person doesn't really present with the, oh, here it is. Well, no, that's not it. This is just like shortened QRS complex. So this person doesn't actually have a T inversion. This person only has the ST depression. So kind of important to know that, like, you know, not every patient have both of these, and they have to have one or the other though in order for you to diagnose them with the end STEMI. Okay, so interesting things about myocardial infarctions, they're not sudden. They happen within hours. So it takes for a while for the myocardial sites to die and necrose, because it's not the dying that you feel, it's the necrosis and the inflammation because the body's trying to get rid of them. So in the acute stage, there's going to be a complete blockage of the oxygen, and then ST is going to be elevated in the acute stage. And it's going to be abnormally rapid depolarization. So this is when the person feels palpitations because the potassium channel opened faster. In the ongoing infarction, this is the death time. There's going to be those Q waves that show up. There's less ST elevation, and then in inverted T waves, fibrosis occurs days afterwards, and then the Q waves, like I said before, persist. And then the infarcted area is electrically silent and negative from now on. So here's the time after onset of the symptoms. After you start feeling like the tightness of the chest, there's nothing quite yet at 18 hours. And then once the muscle starts to die, there's going to be it's going to be pale, of course, because like hemoglobin's gone. And then neutrophil infiltrations, and then they start replacing the scar with the fibrosis. There's going to be granulation tissue. Weeks afterwards, that infarcted area is paler and thinner than the unaffected ventricles, of course, because there's not going to be as much, cells there. And then the granulation continues into the making that scar. The scar is tough and white, dense fibrosis. A problem because scars don't stretch. They don't have the contractility or the elasticity of normal heart tissue. Let's keep going. So this is normal. This is during the first, this is the onset. So this is the acute stage, ST elevation, peak to T wave, first day. So ongoing infarction, ST elevation is even higher, T wave is not as bad. And then more days afterwards, T waves is going to be inverting. 2 to 3 days afterwards, more inversion. There's going to be a very deep Q wave now. And after several weeks, the ST elevation usually goes down, but it can persist if an aneurysm develops, and the T wave gets less inverted. Sometimes it goes back to normal. Some of the R waves start returning, and then the P wave or Q waves stay forever. So QRS. Okay, so that's it for now. Thank you for your attention and good luck studying. Keep all these in mind and practice reading those EKGs.